Welcome to this talking point looking at pain and acupuncture. My name is Johnny Slimming. I'm the clinical lead physiotherapist here at the Neuromuscular Centre, and I'm also currently a lecturer in physiotherapy at the University of Liverpool. So what we're going to do today is to try and define what we mean by this very complicated topic of pain, and to explore some of the definitions which have recently improved in kind of exploring pain as more than just a physiological sensation. We will then try and sort of explore why pain happens in a neuromuscular population, what the causes of that might be, and how we approach things here at NMC. And then finally, we'll look at the mechanisms and the history of acupuncture as an intervention, on how that can potentially provide pain care for people with neuromuscular conditions. So in defining pain, this is the definition provided by the International Association for the Study of Pain, or the IASP. And you can see that they describe it as an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So pain is often something that we think of in relation to an injury or an illness, but it doesn't have to be. And actually, we don't need injury or illness to experience pain. It also recognizes that pain is a very emotional and individual experience. So the IASP identifies 6 key takeaways. That pain is always a personal experience, and that it's influenced not only by our biology, but also the way we think and our environment and our sort of relationships. Pain and nociception. Now, nociception is the nerve endings which are in tissue, which detect tissue damage. So pain and the detection of pain, as it were, are different things. We can't look at pain solely as an expression of how nerves are firing, because individuals have many different life experiences and many different social and psychological factors that influence their experience of pain. We learn pain as we go through life, and pain means different things to different people. Some people who have perhaps certain religious beliefs view pain in a much less negative sense than individuals, perhaps who are a bit more isolated, perhaps have other conditions such as depression, where they're liable to think about pain as a more negative experience. Pain is incredibly individual, so we have to recognize that pain is an experience that is valid to each and every one of us, and that valid experience should be respected. It's no good just relying on a score out of 10 for that pain experience. We want to learn as much as we can about it, but we should never sort of belittle someone's experience of pain, because ultimately we don't live other people's experience. And although pain often serves to protect us from danger, it can become problematic, and we'll look at this in a sense in the second when we look at the fear avoidance model of pain. And there's lots of different ways to measure it. We rely often on verbal communication when we're describing pain, but that's not the only way that we can express it. Our body language and our kind of visual senses. There's other ways of communicating pain through things like drawing and expression and other forms of artistry. So, we don't just rely on verbal description. And that's what the IASP recommend that we do when we're thinking about pain in definition. Perhaps in a more medical sense, we think of these terms in order to sort of perhaps identify the type of pain, or perhaps identify the location of pain. We often describe pain as acute or chronic. And acute pain is what most people experience associated with an illness or an injury. It's associated typically with a problem within our tissue, inflammation, or some sort of damage. And usually when our body heals that damage, it goes away. Chronic pain is pain that someone is experiencing for months or even years. And that can be associated with a long-term illness. For example, if you have something like arthritis, that's a chronic illness, and it causes pain, so you have a chronic pain. But also, chronic pain can uh, be around without any cause, any origin, and we don't need an illness or an injury to experience pain on a long-term basis. Now, the three types of pain relate to the different areas where it occurs in our body. So, nociceptive pain is typically present within our musculoskeletal system, other tissues, connective tissues of our body. And it's detected by special nerve endings known as nociceptors. And it's usually local to one place where the problem is, but it can refer elsewhere. And people often describe nociceptive pain as being quite achy or, like a dull ache, those kind of things. It's not necessarily the sharp, really shooting and stabbing pain sensation. That's often more associated with neuropathic pain, which is pain that originates when there's damage to the nervous system. So if someone's ever experienced a proper trapped nerve, this pain can be similar in intensity to nociceptive pain, but it's often described as shooting, stabbing, burning, lancinating, which is a very posh word for being stabbed. It can be a really horrible experience. But usually it's easy to sort of follow the track of the nerve which is affected. Usually a bit more sort of easily identifiable along a nerve route. And inflammatory pain, if anyone's ever experienced, a hot, swollen, red, maybe they've got an infection or maybe they've got a sprained ankle and it's swollen and it's hot and it's throbby, that's pain associated with inflammation. And again, unless you have a chronic condition, that should reduce, given once that problem has run its course. Inflammation, unless it's a chronic inflammatory state, should only last kind of a maximum of a couple of weeks. So this is quite an old model of pain. This is what we look at from, as described by René Descartes, the philosopher in the 16th century, who identified that information was transmitted from our peripheries up to the brain where it was detected as a stimulus. And often that was related to danger or injury. So, there's a fire here. You touch the fire, it's hot, it's painful, it's dangerous. That information goes up to your brain and we take action accordingly. What we now kind of recognize is that, yes, that might be a noxious stimulus, and yes, that might be transmitted to our brain as sensory information. But there are lots of things that sensitize us or desensitize us to that experience. Some of that is in our biology, our genetics, kind of how sensitive we are to pain tolerance and pain thresholds. But equally, it can be things like our mood, our attention, our kind of beliefs and expectations, prior experiences. If we have a fear of that particular kind of experience, that can sensitize us to pain. And there are lots of models for describing particularly chronic pain, but any pain really. On the left, this is known as the fear avoidance model. And this describes what should be a normal reaction to injury and recovery, where we have an illness or an injury that gives us pain, but we don't develop a fear to that kind of situation or to that experience. And we're able to confront that mentally and recognize that and kind of rationalize that that we're not always going to associate pain with that problem. If you injure your hand on a knife in the kitchen, our usual experience should be that we heal without a lasting sort of wariness or fear of going near that area of the kitchen or doing that activity. And I'm sure we've all experienced this. Well, we definitely have, because any injury that has led you to recovery without problem, you've gone down this road. But I'm sure all of us in some form have ended up in this pattern slightly, where we have a nasty experience, a painful experience, and it sort of colours our opinion in the future. We become perhaps negatively inclined. We worry about that happening again. We try and avoid that situation. And in physiotherapy, this is often true of movement. Maybe someone injures their back while twisting. They might come to think the worst about that. They develop a fear of movement. They're always vigilant for the slightest tweak or the slightest twinge. That then leads us into a cycle of disuse, a cycle of we sort of shut ourselves out from the ability to recover. And often in physio, we talk about cycles in this direction, and we want to get you into that direction. And this is often what we're talking about is the fear avoidance model. Because if we can break this cycle, then hopefully we can get away from reinforcing that worry about pain in the future. And this is one which is present throughout medicine and health now. This is the biopsychosocial approach, and it recognises that we're not just nervous systems that walk around. We don't just receive information and make decisions based on that information. There's a lot that influences our experience of emotion and of pain, and some of that is biological. Life experience sometimes can make us more wise when it comes to dealing with bad situations. Perhaps if we have genetics which sort of predisposes to protection from pain, that can, we've all met somebody who seems just very tolerant of pain, but equally, we can be affected by a whole range of different topics from a biological perspective, but also, what's our mood in that moment in time? What's our social sort of environment in that moment in time? Are we better or less able to cope in that moment? Is our support network helpful or unhelpful in sort of reinforcing or diminishing our experience of pain? Often when people are very sensitive to to people being unwell, or it can sometimes reinforce that experience of pain and be unhelpful. So there's lots that goes into this model, more than just the stimulus of pain itself. Because as the IASP defined, we don't need physiological injury to cause pain. There's all of these other factors as well, and that's how we always try and treat as physiotherapists. So why do we see pain in neuromuscular conditions? Well, that's a difficult question to answer, because there are lots of reasons which might underpin this pain experience, but we know that it is very common. Those of you who've been to NMC for a little while might know Dr. Chris Morse and his research team, and they explored pain experience in neuromuscular populations. And you can see there they found that 90% of people, more than 90% of people, experience pain on a weekly basis. And there are lots of reasons, as I say. Having a neuromuscular condition doesn't preclude you from having other conditions. I mentioned arthritis before, that could be another one. Even things like naturally aging, our bodies just get a bit more sensitive and a bit less good at recovering, and that can give us predispose you to injury or illness. I think one of the keys in neuromuscular populations is we don't fully understand why pain is more present in these populations. But as you can see from some of the maps there, it does seem to tie in to areas where we experience muscle weakness particularly. So for example, in facioscapulohumeral muscular dystrophy, we expect weakness in regions like the shoulder girdle and the neck, and that seems to be where people report their highest levels of pain. So it seems to be areas that are perhaps more affected by muscle weakness, where we experience pain more commonly. And that might be because there is an element of inflammation, or there is an element of ongoing negative change in that tissue. That means that perhaps there is a proper physiological response. Something is being produced by those cells which is irritating the nerve endings in that area and giving us that discomfort. But equally, we know in areas that perhaps are a little bit weaker, that those muscles have to work a bit harder. They can get tight, they can get tense, they can get overworked, and that in itself can be provocative of pain. So having a long-term condition, particularly one which causes us to adapt, change our posture, change our gait, make use of walking aids, make use of powered mobility aids, which keeps us perhaps from being as active as other members of the general population might be. All of these things can have a big effect on our experience of pain. We know as physios that actually one of the very best things for minimizing pain experience is exercise and physical activity. So if you're less able to access that, then again, this is another reason potentially which can influence your pain experience. But as we illustrated previously on this model, there are so many things that affect our experience of pain. So two people who have the same neuromuscular condition, may experience pain in the same location, but for somebody it might be much more intense and much more unpleasant than for somebody else. It's a very individual way of thinking. And hence why when we look at things from a neuromuscular centre population in our physio team, we're always endeavouring to try and get a very individual report of that pain. So we ask you a lot about it because we want to know a lot about it. More often than not, we deal with pain which comes from people using their musculoskeletal system in a different way. Because they load their joints differently, they use their muscles differently, they ask a lot of muscles which are a little bit weaker because they need to function in life, and all of these things combine to produce perhaps muscle or connective tissue or soft tissue which is just having a hard time. And that kind of makes sense when we look at some of the treatments that work, things like manual therapy and massage and stretching and exercise. All of these things can have a positive impact on pain, which fits with that potential origin model. But we don't need, and often don't unfortunately find, an origin for people's pain experience. So even when we have intervention from various professions, from a medical perspective, maybe through medication, through a physio perspective, sometimes we never know what sits at the root of that pain, because there's so many other factors that can influence it. We can't just look at a physical or a medical intervention for something which is also psychological and also social. But what we do know is that positive relationships can have a really big impact on people's pain experience. There's evidence that suggests that even things like shared laughter with loved ones can reduce people's sensitivity to pain. Whereas if someone perhaps is, in an environment where they may be more isolated and perhaps don't have positive support networks, it can make their pain experience more acute. Attention as well is another one. So if someone is has more time to be able to focus on their pain, they're more likely to have a stronger pain experience. So both of these links here have an element of peer support. The BPS has various sort of publications that provide information about pain experience, but Pain Concern is a really good peer support model charity. They're based in the UK. They have a hotline and they have kind of online resources and online kind of focus groups and things like that to help share positive strategies and develop resilience between people, develop relationships, because often that's what we know provides people with the best relief. So when we look at acupuncture then, this is one of the treatments that we offer at NMC. I'm going to take you through a very brief history of acupuncture and some of the mechanisms by which it is thought to impact pain. Traditional acupuncture is part of a Chinese medicine approach which has existed in some form or another for the past 3,000 years. It was first present in written texts which date to about 2,000 years ago. And it's only relatively recently that it's become popular in Western medicine. And that was often thought to be as a result of kind of American physicians in particular going to China when relations warmed and learning about these techniques and bringing them back. Now we say it's about 3,000 years old. This is a really interesting story, full stop. This was a kind of glacially mummified body which was discovered, caused a bit of a diplomatic stir actually between Switzerland and Italy in 1991. And this is a prehistoric man who was estimated to have lived around about 5,000 to 5,500 years ago. And he was so well preserved that we were able to identify his method of death, um, his last meal, the fact that he was using some sort of medicinal herbs, that his clothing was preserved, but also that he had various health complaints, had a bad back and a bad knee, and had sustained a crush injury to his hand and his ankle previously. Um, and what we see on this body, because of the preservation of the skin, is these tattoos, which an acupuncturist would recognize here on the back as this being part of the bladder line, on the ankle here, this being part of this being the point of uh, stomach 41 on the center of the ankle there. So um, the idea that this is a technique which is perhaps 3,000 years old maybe doesn't tell the full story. It might be a lot older than we think, and perhaps might actually have more of a shared history than just being present in China. But it's a really interesting story if you've any interest in forensics or in kind of in prehistory or that kind of thing. This guy is an interesting tale. There are lots of different types of acupuncture. So at NMC, we practice a Western medical model, which kind of incorporates acupuncture intervention alongside our Western understanding of physiology and cells and biochemistry and healing and those kind of things. But in traditional Chinese medicine, they look at things from a slightly different perspective. As there are imbalances in the body, in different forces that we don't really think about in Western medicine. So things like the life essence known as qi, or imbalances between hot and cold or dry and damp. But it's all about harmony within the body. And then there are other forms of acupuncture as well. So acupuncture just done to the ear or the scalp, or even acupressure, which is using acupuncture locations without needling them. There are lots of different variants of this technique. And it's all based around the idea of specific acupoints and meridians. And there are said to be 12 primary and 8 extraordinary meridians, which combine to produce well over 360 acupuncture points specifically. Now, they're not all equal. Some of them are stronger than others, and they all have their specific indications for different problems, different measurements, different precautions, perhaps depending on where we are in the body. But acupuncture seemed to be a concentration of inflammatory mediator cells, such as mast cells, and sensory sort of equipment, basically. So whether that's receptors in the skin or in the tissue or the muscle or the tendon, but areas which are more neurologically sensitive. And that seems to be why these points have been kind of figured out over all of those thousands of years. And you can see here, this is the stomach meridian. And when we come to treat with acupuncture, we might use local points. So if you had a problem with your knee, we might use points that were specifically around the knee. But then we might also use points which are in the foot or the hand, which are naturally a bit more sensitive areas and which might kind of give us a bigger overall pain relieving effect throughout the body. Now, this is a very complicated image, and I wouldn't expect anyone to understand this in totality, but there are two main reasons that they propose acupuncture works, two main mechanisms. The first of these is on the left, and you can see as we insert the needle through the skin and into the muscle, as we stimulate the needle, we cause fibers to wrap around the needle, collagen fibers. We cause cells like mast cells to release their contents, and we stimulate a kind of anti-inflammatory chemical activity. So if that area is injured, or if it's a muscle which is overworked and has been producing, kind of cells have been working very hard and producing waste products, perhaps, we can try and improve the environment in which those cells are active. And that can give us an immediate pain relief in a local area. It can also help speed up healing, is the proposed method there. The other side of this obviously involves the central nervous system, here the brain. And effectively, when we stimulate an acupuncture needle, we create a sensation which is a bit difficult to describe. It's known as the qi, which means to grasp the life essence. And it's described as kind of like a heaviness, an achiness, a buzzing, a kind of stinging sometimes. Your brain recognizes it as a new sensation and not necessarily a nice sensation. So what we cause is stimulation of our brain's own natural pain relieving mechanisms. So our brain has a natural opiate system where chemicals are secreted into the spinal cord and other areas of the central nervous system, which essentially turn the volume down on the pain that we're experiencing. And what that means is if you're in pain and you have an area of your body which is kind of not very happy because it's injured or it's overworked or for some other reason there's a problem. Not only do we get an improvement in the local environment, but also we cause our brain to just turn the volume down a little bit. And that can mean that perhaps that night we get a better night's sleep. If we get a better night's sleep, there's more healing and recovery happens within our body. So we talk about cycles again. Suddenly we get out of this cycle of, being in pain. So, that affects our sleep, that affects our recovery, that affects our mood and our attitude and our kind of our social interactions. And maybe we start getting the problem going in the other direction. So now, um, our pain is reduced, so our kind of experience of sleep is reduced, is improved. Sorry, our recovery is improved. That in turn reduces the pain. That in turn improves, kind of our mood and our attitude and our belief that things can get better and improve. And suddenly we end up in a more positive feedback loop, which is where we want to be in terms of um, managing the pain. Now, for people with neuromuscular conditions, obviously, if the problem is arising from muscle which is overworked or which is tight or which is, uncomfortable, acupuncture might provide some relief, but we will always need that ongoing intervention. And it works differently for different people. Some people, acupuncture has very little effect on whatsoever. Other people, it has a really profound effect on. And obviously, the majority of people are going to be in the middle. So it's another one of these treatment techniques where it won't be the thing for everybody. It can work really well for certain groups of people. It can work okay for other groups of people. Sometimes it's the best choice for a certain problem. Other times there are better options available. So, and we would always look to try and supplement it with, people becoming more physically active and maintaining physical activity, which is, a really the key to kind of sustaining a pain relieving effect is getting all of the benefits from being physically active as best we can. And that comes alongside these other pain relief interventions. There's a great benefit to being relaxed as well, particularly if you've got overworked muscles or you're a bit stressed. And actually, the intervention of acupuncture itself requires you to sit quite still or lie quite still for maybe 45, 50 minutes, something like that, which sometimes is precious time, isn't it, in a busy life to be able to switch off and just calm yourself and relax. So it can have a really positive effect from that perspective. And for every individual that we explore acupuncture with, there are some reasons why maybe we'd be unable to do the technique. If people have perhaps your blood pressure's a bit up and down and a bit unstable, or maybe you've got an allergy to certain types of metal, or maybe you kind of have some other health condition which is listed when we go through the consent procedure. It might not be the best treatment from if you're on quite a high dose of blood thinners, for example, we wouldn't want to be causing you to have excessive bleeding, that kind of thing. But for most people, there's no reason why we can't do this intervention. And we'll always start steady with it. We never kind of go like a bull at the gate first time. There are some possible adverse effects that we can experience, but they're very either very mild or they tend to be very uncommon. So sometimes people can feel a little bit lightheaded. They can feel a bit woozy afterwards. Um, the most common one is that we get a tiny blob of blood or a little bruise at the needle site. Obviously, bigger blood vessels we can avoid through care in our point selection and our needling. Um, Blood vessels on the surface of the skin we can see, but if there's a little capillary or something that the needle passes through as we're treating them, yeah, unfortunately, there's not much we can do about that. Very rare side effects usually occur as um, uh, as a misuse of the treatment, really. So you can potentially, with a sharp needle, cause damage to any structure in the human being. Um, but I'm proud to say that physiotherapists in the UK actually have the best safety record when it comes to doing acupuncture, um, compared with, for example, doctors or traditional Chinese therapists. So it is a technique that requires a really good understanding of the anatomy underneath the area, and physios tend to have that as part of their toolkit. But there you go. There's a bit of an overview of acupuncture as an intervention and of pain in neuromuscular conditions. If you do have any queries or you want to explore this a bit further, then all you need to do is have a chat with us if you're coming into NMC, or you can get in touch with the physio department. It's a bit of a whistle-stop tour. This is a big area when we talk about pain and we talk about acupuncture. So the caveat here is, this will be unique to you as an individual if you have a pain experience. Um, something that I've said here might not tally totally with your experience, and that's fine. That ultimately is what we would look to and respect, is the individual's experience. But it's it hopefully provided you with some of the understanding in terms of how clinicians think about pain, how we talk about pain, and also acupuncture as an intervention. So if anyone does have any questions, then please get in touch. But thank you for your attention and for listening.